Welcome to the 2021 Texas Hypertension Control Summit. On behalf of the American Heart Association, the Texas Department of State Health Services, the American Medical Association, and the Texas Cardiovascular Disease and Stroke Prevention Partnership, I want to thank you for being here today and for your ongoing efforts toward our shared goal to improve blood pressure control rates to greater than 70% in Texas, one patient at a time. This event has grown exponentially since year one, when it was originally hosted in Houston. Then it became a statewide event in year two and a virtual series in years 3 and 4. This movement has become stronger due to the commitment of the leading organizations and really grown deeper due to the participation of every organization engaged here today. I want to welcome everyone, including those who have joined us for the first time and those who have been returning year after year. My name is Allison Smith. I'm the program director for Targeted BP, and I am going to be serving as your MC and your moderator today. I have the pleasure of working with the AHA and AMA on a daily basis with Target BP, and I will help guide us through our really packed and exciting agenda today, highlighting the expertise of national and local leaders and sharing resources to either start or grow your self-measured blood pressure program. So first, just a bit of housekeeping. Everyone except for the speakers will be muted to manage the background noise. And now that we're all Zoom experts, we'll be using both the Q&A and the chat functions. So if you have a question for the speakers, please use the Q&A function. And you are able to actually upvote that question. If you see a question that someone else answered and you have this asked and you have the same question, upvote it and it'll rise to the top of the pile. We'll also be trying to get to as many of those questions and answers as possible, either through direct written responses in that Q&A panel or through the panel discussion. We'll also be using the chat function, and we'll be dropping links to key resources in there as the presentations unfold, and we'll invite you to share your comments in there as well. So to begin with, we'd love to invite you to introduce yourself in using the chat function, your name, your organization, and where you are in your SMBP journey, whether you're planning a program, implementing a program, or scaling it up. So we would encourage you to introduce yourselves in the chat so we get a flavor for the breadth and depth of the more than 100 participants who have joined us today already. So great to have you all here. So as the agenda unfolds, keep sharing your comments. And again, we'll get to as many of those questions as we can through the Q&A function, as well as through the panel discussion. The webinar is being recorded and it will be posted on the 2021 Hypertension Control Summit Series webpage. It'll also be emailed to registrants afterwards. And as a reminder, you'll be seeing throughout the presentation of the program, there'll be slides and a presenter sort of side by side, and there's a slider bar in between those two panels that you can adjust to your preference. Our introductions for speakers and panelists are going to be brief today because we want to preserve time for the really valuable content they have to offer us. So to start out today, we're going to dive in, and I have the pleasure of introducing two representatives of our host organizations, and we'll hear from two more toward the end of our program. But to start with, I want to introduce Dr. Eduardo Sanchez, who is a returning speaker to this annual event. Before joining the AHA, Dr. Sanchez served as the Vice President and CMO of Blue Cross Blue Shield Texas, where he focused on worker and worksite wellness, clinical prevention, chronic disease management, and focusing on diabetes and cardiovascular disease specifically. From 2001 to 2006, he served as the Texas Commissioner of Health, overseeing statewide public health, mental health, and substance use disorders. And he provides medical leadership to Target BP for AHA and serves as the principal investigator for the National Hypertension Control Initiative, which is providing technical assistance and training through an Office of the Minority Health Collaboration to 350 HRSA-funded health centers. So without further ado, I'll invite Dr. Sanchez, the Chief Medical Officer of Prevention for the American Heart Association. Welcome.
Thank you, Allison. Good morning, everybody. Good afternoon, actually. It's just afternoon. I'm so pleased to be participating. I do want to thank the Texas Department of State Health Services, a place I still loved and miss, for y'all's collaboration on this Texas hypertension control effort. What I'm going to do very quickly is to provide a little bit of national context um, uh, and related a little bit to COVID, but come back to hypertension and provide a little bit of an update on Texas hypertension control efforts. Y'all may know some of this, but just to contextualize, set the stage for the conversation today. And I also want to thank panelists and colleagues who are going to be presenters on today's webinar. Next, let me just start here. So pre-COVID, you know this list. This is the national list, causes of death. And for a while, heart disease has been the #1 cause of death in the United States. Stroke actually has moved down the list. But in 2019, #1 and #5 causes of death were heart disease and stroke, respectively, responsible for about 800,000 deaths, constituting about 30% of deaths in the United States. Next slide. Then along came COVID, and there were a couple of things that became evident somewhat early on, and that is that there were underlying medical conditions that put people at risk. And next slide, there were a set of underlying conditions that might be, language of the CDC, might increase risk in folks. And hypertension is one of those. And that's one of the reasons I wanted to put this here. But if you think about the previous list and this one, let's not go back. With hypertension go many of the other things that are on the list: cardiovascular diseases, severe cardiovascular diseases, type 2 diabetes. Next slide. I wanted to talk about COVID-19 and use that high risk to show you some information that you may have seen already. These are causes of death provisional list for 2020. And what I want to highlight are a couple of things. #1 and #5 are still heart disease and stroke, but #3 is COVID-19. COVID-19 was responsible for almost 350,000 deaths in the United States in 2020, almost 10% of deaths. There is an error on stroke deaths, so I'll make the correction here in my head. But what you can see is that heart diseases is still #1, stroke is still #5, but the number of deaths in each of those categories has gone up. And not only has the mortality rate gone up, the crude mortality rate, but so has the adjusted mortality rate. So COVID-19 not only killed people as a result of COVID-19 itself, but it seems to have had a negative effect on causes of death related to other diseases. Next slide. The other thing that was noted early on, and this is pre-vaccine information, and that is that there was a disproportionality to COVID-19 mortality. And it was substantially higher among Blacks compared to white persons. And then you can read the list that for different race ethnicity groups, mortality rate was higher than for whites in comparison. Next slide. And that's important for a couple of reasons. One, I already talked about the relationship between some underlying conditions and COVID. The disproportionality that we see in COVID-19 mortality is not exactly reflected in hypertension prevalence and or control, but there is a race ethnicity relationship that says, there is some disproportionality, particularly Blacks compared to whites, Latinos compared to whites, and Alaska Native American Indian compared to whites. But in addition, when we look at leading risk factors for cardiovascular disease, and remember, I related COVID severity and mortality to underlying medical conditions, among them with cardiovascular disease. Not only is hypertension a risk, but so is cardiovascular disease itself. Hypertension is the leading risk factor for cardiovascular disease, at least according to Yusuf et al. Next slide. Now what I want to do, and that was just a very, very, very high level rationale around why we should be focusing on hypertension. It's where the money is, and it is a risk factor for a number of things that could perhaps be mitigated if we got hypertension under control. The hypertension control movement, as y'all know, is aiming to increase blood pressure control to 70% or better, and to bring us all together to work collaboratively to do that. This objective, the objective of today's session, is to focus on self-measured blood pressure monitoring. Next slide. This is an effort that began in 2018, as Allison stated earlier. Some collaborative, regional collaboratives were created. The goals were set, and the work of the collaboratives and the hypertension control movement got started and is ongoing. Next slide. What you can see is that there are 9 collaboratives. And you can see on the map, and I'm not going to go through this, the prevalence of high blood pressure among adults by public health region in the state in 2019. Again, the goal is to get to 70% hypertension control. This is just telling us the prevalence. But if you go to the next slide, you'll see that we've got some of that prevalence data by collaborative areas. And you can see that there is a range and an opportunity to bring all of the regions up to a 70% or better performance rate. Next slide. These are the improvements that have occurred over time among those who are reporting through Target BP. I want to be real clear. This is through reporting on Target BP. You will note, however, that the numbers from 2019 to 2020 are down in terms of the total adult population that's in the reported population. And there are so many reports of trends of less people seeing their physicians, less patients being seen in many, many healthcare settings. So this is not inconsistent with that. Next slide. That's my cue to hand this off to my brother, Mike Raycos. Thank you all.
Dr. Sanchez, thank you so much for that overview and putting into context the important work that has gone over, that we've been investing in over the course of the last many years, and highlighting some of the unique challenges of the last year in terms of hypertension control. We are grateful for those of you who have continued to participate in Target BP during a very challenging time, but we've certainly seen the challenges of bringing patients into the office, and it obviously one of the reasons we're here to talk about self-measured blood pressure today. Now it's my pleasure to introduce Dr. Mike Raycos, Vice President of Health Outcomes and the clinical lead for Target BP for the American Medical Association. He oversees efforts at the AMA to develop and implement the national quality initiatives, including AMA's MAP-BP and evidence-based quality improvement program, providing a clear and significant pathway to improvements in blood pressure control. The program is offered at no charge by the AMA to healthcare organizations participating in Target BP who want to improve their blood pressure control rates. And he is, as I said, AMA's clinical lead for Target BP and for AMA's work in preventing type 2 diabetes. So with that, I will turn it over to Dr. Raycos. Thank you.
Thank you, Allison, and thank you, Eduardo, and thanks everyone for taking the time to attend today. My goal here, as Eduardo talked about, the hypertension nationally and the impact of COVID and cardiovascular disease, I'm going to drill down a little bit more into self-measured blood pressure monitoring, or SMBP, and really try to set up the speakers who will follow to talk about what's going on in Texas in their healthcare organizations. This will be a high-level overview, and hopefully it will generate some questions and stimulate some thought about what the panelists are saying to follow. Next slide, please. So I have no disclosures. Next slide. And I think I already reviewed what we're going to talk about today. So let's just go right into the next slide. So what's new? When we think about what's new in SMBP, we have to go back a little bit. This study was published a couple of months ago, and it was a survey done from 2019 called the Behavioral Risk Factor Surveillance System, or BRFIS, from 2019. And what was unique about 2019 was it was the first time states were given the option to participate in an SMBP module, to have people in those states who responded. And these are patients with hypertension, or people with hypertension who I'm going to look at here on this slide. 20 states plus the District of Columbia agreed to participate in these SMBP questions. And so we have almost 67,000 people responded with the diagnosis of hypertension. And the set of questions was pretty basic, but basically the first one was ask people, has your healthcare professional recommended SMBP? And not a surprise, 70% said that their healthcare provider had recommended measuring blood pressure outside of the office setting. Now that could include a community, a pharmacy, a kiosk, or at home. And another not really surprising answer from the participants was that for those with hypertension, a majority of them said that they check their BP outside of the office, regardless of whether a healthcare professional recommended it or not. So 60% responded that they do measure outside of the office. Next slide. And now as we focus on those who checked outside of the office, 85% said they checked at home, which I think is not a surprise again, but important. What I do think is surprising, and you can hit the spacebar a few times here to get the statistics on the right side up, but for those with the diagnosis of hypertension who measured outside of the office, only about 7% of the time were those blood pressures communicated using broadband by email or the internet in some way. Only 5% of the time were results communicated to healthcare teams via telephone. And a vast majority of the time, 74% of the time, nearly 3/4 of the time, it was at in-person visits, which really I think is surprising, that when people perform self-measured blood pressure at home with a diagnosis of hypertension, they only really communicate their results a majority of the time in person. And in 2019, this is again pre-pandemic, it's important to note that, but I think on the next slide, becomes more important as we get into looking some of the first COVID data. This is from 2020, looking at the second quarter of 2020 compared with the 2 prior years, over 100 million visits in primary care. And what we saw was a 50% decrease in face-to-face office visits in primary care. I think that's really important to note. So when you, and again, this was over 100 million visits that were looked at. And when although we saw a 50% decrease in face-to-face visits, much of that was made up by telemedicine visits, either with video or telephone. A 30-fold increase in telemedicine visits didn't gain all of that back, but unfortunately, blood pressure assessments occurred during those 35 million visits, less than 10% of the time. So I think the takeaway from these 2 slides is that even though a large percentage of providers recommend out-of-office measurement, and a large percentage of people who do out-of-office measurement do it at home, almost a majority of them share that information only in person. And this is really not taking advantage of the technology, the convenience, the efficiency of how we can leverage SMBP if we had a better way to communicate results in a non-face-to-face way. And that's really a big part of what I think this information exposed. We weren't great at this pre-COVID, and we certainly are not doing well during COVID in this way. And even though face-to-face visits have returned, they're not quite at the level they were before, and telemedicine visits remain. And so we've got to find a way to figure this out quickly. Next slide. We don't know yet what the impact will be from that lack of data being shared, and it'll be interesting to track outcomes over time. We do know that blood pressure control rates still remain lower than before the pandemic. So I'm not going to go through all of these, but we know that there are an evidence-based approach for using SMBP to effectively lower blood pressure and improve blood pressure control. This includes identifying people who either need to be diagnosed with hypertension, have that confirmed, or those that are already diagnosed. You need to set a target population that you want to use SMBP for, and there are clear indications for that. You want to make sure you have an accurate device with appropriate cuff sizes needed, and provide culturally appropriate and linguistically appropriate patient education materials at the appropriate level of health literacy for the people that you're trying to communicate with. This is critical. And then an evidence-based measurement protocol, processes to receive and transmit SMBP data, appropriate interpretation of results, and sharing a shared treatment plan between patients and care teams. Next slide. So let me just very quickly talk about some of the challenges, and then I'll propose some of the potential solutions. So we know that when we look at people using SMBP, there is a lack of understanding of the benefits for this often asymptomatic condition. There's confusion and challenges around the frequency of measurement, or the perception of how frequently people think they need to measure to do this right. They might think that it's multiple times a day, every day, but it's not. Out-of-pocket costs and transportation are issues that we have to address, but there are some potential solutions there. And access and use of technology continues to be challenging. People report this as challenging. It seems like it would be convenient if we did it well, but it continues to be a challenge. For providers and clinical care teams, not trusting the accuracy of devices and the blood pressures being reported, increased workload in training patients and processing and results and communicating treatment plans, lack of reimbursement for patients on devices, still strong concerns. And for health systems, just not really having the systems in place and the technology and the financial incentives or knowing how to use them appropriately to subsidize SMBP programs to make it cost effective. So we can go to the next slide. So we like to talk about, just to now simplify things a little bit, what are 3 critical factors here for using SMBP to actually lower blood pressure and improve blood pressure control? And let's go to the next slide. We'll talk about the importance of using an accurate device. So you need to have an accurate device validated for clinical accuracy. And to overcome the concern about that, there is now a US blood pressure validated device list, which has devices that have been independently tested for accuracy for both office and out of office use and community use. You can see here, and this has been something that this list is growing rapidly. It's a great resource to make sure that if you use one of the devices on this list, that it will be clinically accurate if used appropriately. Next slide. And this is another, very simply stated, we need to use guideline-driven patient education and user instructional tools. And so this is just a sample. Allison will talk at the end of the presentation today on the importance of using some of these tools. And really, we've been long overdue in having more languages available. You'll see here we've got English, Spanish, and Vietnamese for these resources, and a couple of videos that are very, very key. These are located on the Target BP website. And again, I put an address here, but Allison will talk a little bit more about tools. And on the next slide, we could probably spend an hour really talking about how does the data flow? What about the access and use of that data? So first and foremost, people, when they're measuring their blood pressure, need to have a way to capture that data, whether it's on paper, whether it's stored in the device itself, or whether it's transmitted somewhere to a mobile app or a portal or providers directly. And when that data is captured, it then needs to be relayed. And this is critical, the relay of that data, whether it's verbally on the telephone, as we saw happens 5 to 7% of the time, whether it's relayed via an app to a portal or into the EHR, whether it's manually entered into a portal, whether device storage is viewed directly or via a telemedicine encounter. And what we're seeing more and more of that is very desirable is direct cellular transmission, really key, really important, because it eliminates a lot of the steps for patients to have to deal with more technology. They can put their arm in a device and it transmits directly to where it's programmed to. And then there's ingesting the data, which is really critical. And we're starting to see a lot of interest in studies around how much data should come in, what's the best workflow or workflows to process that information, average the data, share the information with providers, and then use a team-based approach. We'll talk about that in just a minute. And then there's the correct interpretation of those results, which is a little bit different than in office, and then documenting and communicating a plan. So these are the 3 critical areas. And if we go now to the next slide, I'll spend a little bit of time talking about some potential solutions here and we'll wrap it up. So if you hit the space bar once, so challenges for people using SMBP, you see here listed on the left that I've mentioned. So we talked about the importance of having culturally appropriate and appropriate level of health literacy for the information and tools and resources used for training. We really need more device coverage with AMA and AHA are working very hard on. And free or low-cost access to broadband, to cellular, Wi-Fi, and data plans is starting to happen with the FCC. It's been happening during the pandemic, but it's really starting to be used more by networks in some really innovative ways through the FCC's emergency broadband programs. We could talk about that in the Q&A if you're interested. And we really need easier to use digital tools, resources, and mobile apps. As far as challenges for providers and clinical teams, we talked about the validated device list, but I think spending more time focusing on team-based approaches, leveraging community health workers for training and pharmacists and RN-driven programs, really critical. Getting devices coverage, which we mentioned, and then using the CPT codes that are available for remote monitoring and SMBP, and demonstrating the ROI so that we can get more health centers and health systems buying devices, handing them out to patients, and then using these reimbursement codes to recoup that investment. And then finally, for systems, having the ability to have a device procurement plan so you can attain the correct number of accurate devices, integrating the data into EHRs, improving workflows, and leveraging high blood pressure quality measures, which all now allow SMBP in one way or another. And I'll wrap up with that. We can talk a little more in detail on the next slide. You'll just see I've teed up a little bit more information about the SMBP CPT codes and controlling high blood pressure quality measure changes. Just realize, again, all national blood pressure control quality measures now accept home blood pressures or SMBP data, most now allowing patient reported and not transmitted, if not now by 2022. We can talk about that a little more in the Q&A as well. And just to stay on time, I will finish there.
Dr. Raycos, thank you so much for highlighting some of the challenges and progress being made during the last year. The pandemic has certainly fast forwarded the longstanding clinical recommendation for SMBP, but not without its challenges. And thanks for emphasizing really the importance of relaying that SMBP data back to the care team. It's not the device itself that controls blood pressure, it's the information that informs decisions to make treatment intensification decisions and supporting patients and adherence. So thank you for that. And I appreciate the resources that you shared, many of which have been dumped into the chat. So you all can access those immediately through those links, as well as through the slides and recording that'll be distributed later. Thank you both, Drs. Sanchez and Raycos, for giving us a little bit of a background and update on the state of hypertension control in Texas and some of the emerging national trends that we're seeing, and for your ongoing leadership of this movement. So next, we have the pleasure of hearing from 3 different Texas health centers as they discuss their journey with their SMBP program. Again, reminding you to use the chat for any comments, but also invite your questions in the Q&A so that we can either address through responses in the Q&A or during the panel discussion. So our first team of presenters from Tamagua Healthcare Ministries is Tamika Simmons and Diane Gale. Prior to joining Tamagua, Ms. Simmons had led a dynamic 20-year career in healthcare administration with strengths in leadership, public relations, and strategic partnerships. She has a real relentless passion for community development and is a member of the Public Policy Committee of the National Association of Free and Charitable Clinics, also the Texas Association for Free and Charitable Clinics, and a member of the Community Advisory Board for the American Heart Association, among other professional involvements. Also, Diane Gale, the Director of Nursing, has more than 10 years of experience in bedside nursing and clinical management and cardiovascular critical care. Prior to joining Tamagua, she led HCA Houston's healthcare tombo in achieving high quality standards to chest pain accreditation and AHA's Mission Lifeline Gold recognition for STEMI care. She was a pioneer in creating their PPE program in response to COVID and introducing many other innovative ideas and processes. So with that, I will turn it over to our team to share their SMBP insights. Thank you both.
Well, hello, everyone, and you can go to the next slide. I'm Tamika Simmons, the CEO of Tamagua Healthcare. Just to give you a background, our mission is to provide quality healthcare, offer hope, and restore dignity to the vulnerable populations in a 600 square mile area of Harris, Montgomery, and Waller counties. Next slide. We are a teaching facility. We are a Christian-based organization, but we do take care of patients regardless of their religious affiliation, and we provide access to residents, as I stated, in a 600 square mile area. It's more of a rural part of Harris County, Montgomery County, the southern part, and Waller, where there are a lot of disparities, including being medically underserved, physician shortages, transportation barriers, no pharmacies, little hospitals. That's kind of our expertise to make sure residents in those communities receive the care they need. And we've been here 32 years. We focus on patients who are at 200% or less of the federal poverty level, regardless of their ability to pay. Next slide. We have several service lines. Family medicine is where we started, and then we brought on full CLIA wave labs in 2 of our facilities. We have Class C pharmacy on site and full comprehensive dental services, including optometry, diagnostics, and case management. During the COVID-19 pandemic, we introduced our food pharmacy and telemedicine services. Next slide. Now, the teaching facility piece with us is very important. It allows us to bring more services in. We pride ourselves in being part of a lot of cancer research and prevention because of those partnerships, in addition to bringing more healthcare professionals to this area to meet our needs. Our volunteer involvement brings in about $250,000 a year in services that we do not have to pay for, and our partnerships with hospitals and organizations help us offset about 50% of our budget so that we can provide the services we provide. Next slide. So now I'll have Diana speak with you guys about our program that we launched during COVID. We started talking about it beforehand, but during COVID is where we really brought on the self-monitoring program because of the community we serve and the location we're in. And we knew that that would be something that would be a challenge for our patients. So Diana.
Thank you, Ms. Tamika, and thank you guys to everybody who's listening in and the panelists. This is an honor to be able to share our process through all this. So self-monitoring blood pressure program, really what had been said in the previous slides, providing the purpose of it is providing patients diagnosed with hypertension with blood pressure machine for home use to be able to track and manage their own blood pressure, have that engagement where they're really fitted in into owning their care plan as well. Tamika Simmons, our CEO, was a very big part of it, as well as the supporters of Dr. Linda Flower. She's our medical director. And then, of course, our clinical staff, including our nurse practitioners and nursing that we do have, including patient access and scheduling to be able to get these patients in. On the next slide. So the background really of our program is targeting the hypertension patients, the ones that have already been diagnosed, and also due to our patient population that we do take care of here, the majority being Hispanics and Latinos, very complex management due to multiple comorbidities. Also, we wanted to target dental patients. We have dental services, as mentioned earlier, but they were limited in the services that we could provide because of their uncontrolled hypertension. So we wanted to make sure that we are able to provide the holistic care that we do here at Tamawa and manage this hypertension. So according to ACC and AHA, hypertension guidelines recommends target blood pressure of 130/80 and 140/90 for stage 2 hypertension. In 2020, for us, 65% of the Tamawa patients had a blood pressure control of less than 140/90 and a 39% with blood pressure control over 130/80. We wanted to really be robust. We knew our patient population was going to be complex and difficult to manage, multiple medications, multiple diagnoses, but still we wanted to start with the 140/90 as the main goal, right, through AHA, but also really go more robust. And now that we have them controlled, go again lower to 130/80, which is that goal. On the next slide is the workflow that we did. So first is patient identification, really targeting the patients as mentioned before, diagnosed with hypertension, compliant also for at least 1 year. We want to make sure that the patients are going to be engaged and utilize these tools and services that we're able to provide. And then patients with complex diagnoses. We scheduled a consult visit. We discussed their blood pressure monitoring. We went through the blood pressure trends that they have had from being a patient, and then we developed individualized care plans. We provided patient education as well. Thanks through AHA and their resources, we had bilingual education pamphlets available, so we made packets to be able to provide to them. Again, our majority of the patients were Spanish speaking. And so we did have that availability. So it was a great resource to have, to sit with them, to review the education, really make sure that they understood it. We did the program was for a 3-month loaner program agreement. We did have an agreement as well that was all part of the package through AHA to make sure that we did have them sign and agree to this 3-month program, to agree to track their blood pressure readings. And then come back and do the follow-up visits. So that was the next step on a monthly visit schedule that we had them at to review their blood pressure logs. It was a written form, I think it was shown in one of the slides in the previous presenters, and we would review those. Now, we also were very specific that if they had certain readings, so for example, greater than 190, multiple readings at a time, that they should seek, emergency help, or go to the emergency department and seek a lot more help to have that controlled and not just sit on the high blood pressure or even on the low side as well. We do have patient portal access. So it's all through the internet, where they can also submit this either by email or by picture as well and sending it over. So we're able to track that as well in case that they can't come or can't send it. So that was also an option that was very convenient. And then at the end of it, we wanted to also inventory the blood pressure cuffs that we had and we had lent out. So we had a loaner device tracking sheet where we would write down the patient's name and who got the blood pressure cuff. And then as we had them returned or as we reevaluated these patients that already had their blood pressure cuffs, then we could get them back and then provide them to new patients. On the next slide is our PDSA cycles. So we went through, different trials to see how it went, see how the patients responded to it as well. So our first PDSA cycle was just basically creating and implementing the policy and procedures. A lot of these tools came from AHA, so it made it a lot easier and streamlined and standardized on what we were saying and what we were teaching. On PDSA cycle 2, though, we noticed that patients may not have quite understood how often they needed to check, what to do. Is it good or bad? Should they focus on the top number or the bottom number, right? Systolic or diastolic, and what things they needed to do. There was also a situation with some of our patients, obese patients, that their cuff didn't quite fit, and it may have read different readings. If it was too tight, if it was too small, those things that can happen with the blood pressure cuffs. So we modified our patient education. We made sure that instead of just giving them a blood pressure, giving them and reviewing the education packets, but sitting with them and actually having them teach back or demonstrate it back to us after we taught them. So they would check their blood pressure right in front of us so that we knew that they were putting it correctly in the right location of the arm, that it wasn't too tight or too loose or anything like that. And then we also adjusted follow-up visits as well, because it got to just the review of the blood pressure tracking monitor as well in their trends. And so we made it a nurse visit to review the blood pressure log. So through our medical director and our provider, they would review these as well, of course. But instead of, kind of taking that time just to review their trend, our nursing team, our clinical team also was knowledgeable to review those trends and be able to give feedback, make the follow-up appointments, answer any questions or concerns that the patient had, and then also relaying it to the providers. And then our third time around, and kind of streamlining this, we adjusted the process of calling the patients as well are they're at their 3-month trial to assure the return of the blood pressure machines. So not everybody, not all the patients stuck with the 3-month in returning the blood pressure cuffs and returning the calls and doing follow-up visits. So we really had to adjust our staffing and adjust our closing the loop of these patients to make sure that they were sticking to the care plan that they were given. So on the next slide is our outcomes. So this is just a simple graph of how we did. October 2020 is really when we started this program and started getting more patients buy-in. So October 2020 through June 21st, 2021, you can see on this chart. 2020 with COVID, it really hit us hard, right? There were a lot of patients that did not want to come into the clinic, did not want to leave their house. They had their concerns about COVID and infection prevention and all those things. So we did the best that we could through telehealth as well in reaching out to patients. That's how we were able to maintain really our clinic and the patient care that we provided to the patients that we had, and specifically to this program as well. So there was a huge drop towards the end of the year. We went up, we stayed kind of stable through the month of April, but then in May and June, we really saw an uptick. Again, due to we were able to really do very robust and specific guidelines with infection control within our clinic, within our team, and be able to bring the patients back into the clinic. And I think that really made a difference in getting the patients face to face, in being able to talk about their management, their trends. They still brought their paper over. We were able to discuss with them, and then that blood pressure management was able to be better as well. On the next slide, it's just an overall quarterly comparison of how we did. So on the blue bars, you can see is the blood pressure control 140/90, and the orange bars is the blood pressure control, most robust goal, internal goal that we had at Tamawa, 130/80. So the 130/80 really it maintained the same throughout each of the quarters. For the 140/90, you can see slightly trending up. So we'll take that. But we're really working on getting the engagement of these patients. Again, COVID really hit hard. Additional education really for these patients as well to make sure that they understand the value of blood pressure control. On the next slide, I'll discuss a little bit more in detail. So we did identify specific barriers in patients' understanding on how to document the blood pressure readings as well. What is good? What is bad? Is it the top number? Is it the bottom number that they should be able to focus on and control? We also identified specific barriers to patients' compliance and follow-up visits. One of the biggest things besides just COVID in general that happened everywhere, I think, is transportation, work schedules, school schedules, having kids, you know, all that, being able to manage that. And we are really fortunate to have a lot of partners, like Tamika was saying, and being able to help and support our patient population to make sure that they get the healthcare that they need. Medication adherence and lifestyle changes is also big due to the fact that they have limited financial resources. So they may not always be able to have access to the medications, may not always be able to go to the pharmacy and get the medication they need, or change their lifestyle, such as diet. One of the things that we really support and teach. So as mentioned also with Tamika, we have a food bank that we offer all our patients. Anybody that comes in through our clinic is very specific. It's through a partnership. We have bags with healthy choices, healthy foods. And we even include education in there so that they understand what it is with what the changes that they need to make that will affect their blood pressure. And then also we recognize, you know, the difficulty of obtaining blood pressure machines back. That's one of the things that that I mentioned, and it's a work in process, and we're kind of still trying to assess that, to really see how we can facilitate that so that we're able to provide more to new patients as we get them. And that'll be it. I think for the Q&A, we'll discuss the recommendations that we had from all these discussions. And I can go a little deeper, more in detail once we get to that point. But I appreciate your time. And thank you.
Team Tamakwa, thank you so much for sharing the methodical approach to designing, implementing, and refining your SMBP program, and for sharing the resources, many of which were dropped in the chat for your reference. We'll be excited to dig into some more discussion. So on the next slide, I want to introduce our next panel presentation. Dr. Lydia Best is the medical director at Baylor Scott & White Health and Wellness Center since 2014. And prior to that, she served as an instructor in family medicine in private practice and a medical director in Michigan. She is a member of the Baylor University Medical Center Diversity and Inclusion Council and serves on the board of directors for Urban Solutions. We are delighted to have you here, Dr. Best. The floor is yours to share your SMBP journey. Thank you.
Well, thank you so much. I'm very excited to share a bit about our self-monitored blood pressure program. We redesigned our program in response to the global COVID pandemic, as much of you have, and we plan to utilize this program going forward. I just want to tell you a bit about our center. The Baylor Scott & White Health and Wellness Center is a Baylor community care clinic conceived back in 2010 to meet the unique needs of people in the southern sector of Dallas. We are located in the Juanita J. Craft Dallas Recreation Center and in close proximity to Fair Park. Our site is a designated food desert, and 75 to 85% of our patients are uninsured. That demographic has fluctuated a bit with the pandemic as more and more insured patients were unable to access care at their usual sources. So we've had more insured patients lately, and we'll talk about that a little later. Next slide, please. In 2019, our standard of care was to encourage self-monitoring of blood pressure by prescribing low-cost automated brachiometers at our Baylor pharmacy or local discount pharmacies, and providing printed handouts on how to self-monitor with verbal demonstrations for people needing extra support. We reviewed logs if patients self-reported that they were monitoring. Our center's president, Vanita Owens, has been advocating for digital care options for the last 5 years. As with many of you, we were finally enabled to embrace virtual care because of the statewide shutdown due to the pandemic. We never stopped medical care, but our doors were closed for just over a month's time, starting in late March of 2020. Evaluating our 2019 model in light of the impending shutdown, we found that we faced some challenges. Next slide, please. Like with most of healthcare, we had to pivot. Our redesign approach included assessing our strengths. We have a collaborative team, including a pharmacist and pharm tech, a social worker, registered nutritionist, a community health worker, and our medical assistants are cross-trained. We have cooking and exercise classes, as well as a weekly farm stand with low-cost fresh fruits and vegetables. In addition, we have a supportive hospital system that funds our low-cost medications and testing supplies. Next, we assessed our gaps, such as a delivery system for dispensing the blood pressure monitors during the shutdown and beyond, as well as finding ways to teach patients how to accurately measure and track their blood pressures at home. We decided to implement a rapid cycle mindset to help keep our patients healthy and combat the phenomenon known as clinical inertia, where we keep doing the same thing despite evidence that an intervention is needed. Next slide. As with all of our care, our goal was to make our self-monitored blood pressure program accessible and user-friendly for patients, and the data analysis efficient for providers and staff. We can go to the next slide. As you'll see on our demographic slide later, we did have some challenges to overcome, especially the digital divide that exists in our community. We had to make sure that we had multifactorial options for patients who may not have had access to digital technology for reporting their blood pressures. For example, our previously untapped circular drive that you may have seen on the first picture served as a makeshift clinic for people with no way to track their blood pressures at home. Next slide. Here are the components of our robust self-monitored program. We had to provide access and education, assess home blood pressures, manage out-of-range values, assure affordable medication access, evaluate the data and make rapid cycle modifications, and find free blood pressure monitors for those who couldn't afford one. Access was heavily dependent on our medical assistants. In the heat of the pandemic, they volunteered to take the lead on drive-up blood pressure checks and distribution of blood pressure monitors, patient assistance program medications, and any other handoffs to patients like written prescriptions, instructions, and samples, and even performed point-of-care testing. Patient education was conducted via telephonic and later video demonstrations by the pharmacy technician. I consider this next part the most important part of our program. The community health worker and the medical assistants took a proactive approach to assess patients' needs, adherence, and barriers during the shutdown by calling all of our patients on our chronic disease registries, including the hypertension registry, to provide concrete support and assure them that they still had access to care. We took a collaborative approach to the management of uncontrolled hypertension, with our providers or our pharmacists tag teaming the patient's video visits. I want to give an example of a rapid cycle response. Our community health worker, Oscar, took it upon himself to become a super user of the different video platforms as they evolved. He led many of our patients through the downloading and use of Zoom, Doximity, Doxy.me, and finally, our own Epic EMR, which is now our sole provider of virtual visits. We had to get very creative, and we found patients who were staff's family members who were willing to serve as our first virtual visit patients to help us tweak the system. This helped mitigate the steep but swift learning curve. Next slide. We've always had the $10 blood pressure meter options at our Baylor pharmacy and elsewhere, but during the shutdown, we felt that the financial constraints may make even these meters cost prohibitive. So we quickly sought sources of free meters, scales, and testing supplies. All of the automated blood pressure monitors meet the American Heart Association criteria and are on the validated device listings. Another challenge was meter supply, especially for the extra large blood pressure devices, as our usual sources faced shortages, not quite reaching the intensity of the toilet paper wars. Our pharmacy lead and our administrative liaison worked long and hard to secure devices for our patients. Also, we did receive a 2019 Target Blood Pressure Award, and after that, the American Heart Association gifted us with an additional unexpected supply of large cuff meters. With the help of the team here, we have distributed over 75 free meters to meet the needs of our uninsured patients who couldn't afford the low-cost meters. Next slide. All of this hard work culminated in our new Empowering Under Pressure self-monitored blood pressure program. We served over 720 unique patients with hypertension in the last year and a half, and 353 of them have a future visit, indicating active or ongoing care. 1/3 of these patients preferred Spanish, and all written and verbal materials were available in English and Spanish. Our patient portal use increased from a low of 40% in 2019 to almost 70% today. Through the Empowering program, we were able to maintain a rate of 78% blood pressure control. This held true for our uninsured patients as well. In this data set, 60% of our patients were uninsured and 76% of them were controlled. This bested our 2019 Target BP recognition from the American Heart Association that we received for achieving a 72% rate of control. Next slide. I performed a chart review on 190 random patients to assess the interventions utilized. Here, we are highlighting the management services that our patients with hypertension received. 25% of them were given a free or low-cost meter after the pandemic hit. This indicates a step up in care and self-management. Several patients had blood pressure monitors already. 56% had a virtual visit. Initially, many were telephonic, but we quickly converted to almost exclusively video visits where we could see the blood pressure measurement techniques and provide demonstrations as needed. Due to a high disease burden, hesitancy with going out to our drive-through pharmacy at Baylor, and concerns over the nominal $4 medication fees, our pharmacist ended up being involved in the management of 2/3 of our patients with hypertension. She was able to waive prescription copays, address medication adherence, and even pre-order required labs. When the shutdown mandate lifted, most of the pharmacist's visits became face-to-face, while the pharmacy tech performed more than 1/3 of her support via the phone. Unfortunately, we did not track the distribution of the free meters in a retrievable way, so that is something we'll have to look forward to doing in the future. Next slide. In conclusion, we are gratified to see that the majority of our patients took up the mantle to self-monitor and report their blood pressures at home. 61% of the total reported using their devices, and almost 70% of those with uncontrolled hypertension were monitoring their blood pressures at home. As planned and expected, we had a more intensive support for our patients with elevated blood pressure. 74% of the patients with uncontrolled blood pressure versus 40% of those with controlled blood pressure had an intervention. Next slide. While performing the chart review, we could see that patients with competing diseases had less medication management for their hypertension. Uncontrolled diabetes was prioritized even when it existed side by side with uncontrolled hypertension. So we need to do a better job of addressing multiple morbidities with our chronic medication management program. The other competing interests were the Coumadin Clinic and depression. So patients that were seeing the social workers sometimes didn't see our pharmacists to have their blood pressure control. And we anticipate doing collaborative visits in the future. And also in the future, we plan on introducing 2 videos, one on how to log in for video visits and one on how to self-monitor at home, such as the Release the Pressure video from the collaboration with the American Heart Association, the AMA, and the NMA. We also want to correlate self-monitoring and the different interventions with clinical outcomes in the future, and I hope to report on prospective outcomes in the future. Thank you for your time.
Dr. Best, thank you so much. Yet another amazing example of very thoughtful program design, the use of data and to refine and refine and refine. I'm just so impressed. You all touched on everything from the digital divide to clinical inertia, community engagement, and beyond. So thank you so much for sharing that. And again, some of the resources mentioned were in the chat. Inviting any questions in the Q&A from the audience, because we have one more panelist before diving into our panel discussion. We'll dig in a bit more deeply with the limited time that we do have. Our final presenter is Dr. Heather Escobar, the Chief Medical Officer at Mission East Dallas Family Health Clinic. Dr. Escobar is a board-certified family medicine physician. She has cared for patients in a federally qualified health center since completion of her training and has served in the role of CMO for the last 10 years, first in South Carolina and now in Dallas. And through her dedicated work toward high-quality care improvement, she's led organizations to Level 3 patient-centered home accreditation and several clinical quality awards from HRSA and other agencies since joining Mission East in 2016. Dr. Escobar, welcome and thank you.
Hi, thank you. All right, so I just give a little bit of background. I don't have a slide that describes our clinic bit, but I wanted to let you know we are a relatively small organization, so a lot of what you're going to see, I sort of think of as sort of grassroots quality improvement. When I came to this organization in 2016, the clinical measurement for blood pressure was at 41% blood pressure control, and within 2 years of engaging in some of the changes I'm going to talk about, our compliance rate with blood pressure control has been at 71 to 72% for the past 3 years. So it really speaks to the efforts of a small organization trying to do quite a lot for their patients. We have both a medical practice, a dental practice. We also have behavioral health services. And on the medical side, helping our patients with self-measured blood pressure. It's 3 providers, 1 RN, and 5 medical assistants. So we really do use a team approach as much as possible. All right, we can go to the next slide. So, I really thought about what kind of questions did we ask ourselves when we tried to improve that clinical quality measure at our organization. And the first was just making sure that we educate and train our own staff appropriately. I think, through the chaos of the day, many of our staff just sort of went through the motions and didn't always think, thoughtfully about what the evidence really shows and making sure we're all across the board following the same guidelines for the same goals. So we started with making sure we adopted appropriate guidelines for blood pressure control and created clinical protocols for our staff members to understand the importance of proper blood pressure measurement. Even that, it may not seem like an important thing, but again, when you have staff who are probably trying to move very quickly, they may be forgetting the important tenets of proper blood pressure measurement. So we made sure to educate and train our staff appropriately for that. We do this every year annually for recredentialing our staff. And of course, we always perform that at orientation as well. We also require that our staff pass a skills observation exam so that they continue to get their credentialing and privileging from year to year to continue to remain on the medical staff. All right, next slide. So this is just an example of part of what's in our guideline and our protocol. Very familiar, I'm sure, to all of you, but these are reminders that we keep in our policy manuals and that we review with our staff on a continuous basis, making sure that we're properly measuring and using the appropriate size cuffs. I think what's important here too is that in having your staff understand the details of appropriate monitoring, we can then educate our patients about that. Next slide. So that's the next piece, really, is then to teach our patients how to self-monitor appropriately. So we do that in a variety of ways. First, obviously, is the patient visit itself. There's been a lot of discussion from our previous speakers about how that has changed in the time of COVID. Certainly, we're doing a lot more telephonic visits, video visits. So that doesn't always give us the opportunity for the typical blood pressure measurement, but we do review the main tenets of how to appropriately measure that at home. So we make sure we are using our protocol appropriately. We certainly have lots of patient education materials. And really, I find that more than anything, talking patients through the process is the most important. Because frankly, I'm sure all of us realize our patients don't go home and read through, 5 pages of materials that we hand them. So really education, walking them through it while they're here, even if in this last year or two, if we may have only seen them once in person, that's the time we have to take the opportunity to do so. We've also found that it's important for us to review the possible triggers for elevated readings, making sure patients understand the most opportune times to check their blood pressure, and advising them to avoid situations where they're going to have some natural elevations of their blood pressure, such as reminding them that they shouldn't, shouldn't be smoking at all, but certainly not right before they come here for a blood pressure check or before they're going to check at home. Reminding them about some simple things like exercise or drinking alcohol may give them some temporary elevations. So I find many patients don't really get told that and haven't understood that those kinds of things can affect their readings. We also really encourage patients to bring their home monitors to their visits so that we can check them against the accuracy of the equipment in the office. We find that has helped our providers to feel a lot more comfortable in relying on the measurements that the patient might be providing from home. And it's also given us the opportunity, again, to educate them about what the appropriate monitors are, the best ones, why they may not be working correctly, and help them to work through some of those issues so that they can be more reliant on some home measurements. We can go to the next slide. So then, of course, we need to provide them with self-monitoring tools and resources. So we give them a few sort of key flyers and handouts to remind them about the proper blood pressure monitoring technique, how to sit appropriately, how to have the arm elevated, and so on. We also provide them with blood pressure logs, making sure to indicate the normal range that we're looking for them to fall in. We very heavily rely on the DASH diet for encouraging them to make some lifestyle changes. And then, of course, where we can, we order home monitors and ambulatory monitoring services. We work with a home healthcare organization called named Veritas. They have helped us with getting our Medicaid patients onto home monitoring services. I believe now with some change in legislation last year or two, Medicare is also approved for that, for coverage there. So more and more, as we find patients who are eligible for that, we sign them up, particularly if we consider them that they are high risk or have multiple comorbidities. And I think we'll mention a little bit later too, of course, we also look for low cost options for blood pressure monitors, and we have several resources in the community through our partnerships with places like community churches and other organizations where we can find some donated options as well. Next slide. All right, so this is just an example. We use a lot of the materials from the American Heart Association, of course. So this is a simple one that reminds them about how to appropriately measure the blood pressure recordings at home. Next slide. And this is also just a reminder we give them about some of the lifestyle changes to continue to work on their own in between visits. Next slide. All right, so the follow-up, of course, then is the next step for us to take a look at what those numbers are doing. We really do stress routine follow-up with the patient. Again, we've had to be creative in the last year or two with COVID, doing a lot more of this telephonically or by video. But we do also continue to use, as we have for years, our quality registries in relation to hypertension control, so that controlled patients are encouraged to be following up with their provider at least every 6 months. If they're in pre-hypertension range, every 3 months. And if they are uncontrolled, then we're trying to check in with them every 1 to 2 months. So we have that chronic disease reminder system in place. We are using our EMR to send out audio and text reminder messages to these patients to try to encourage them to keep their follow-up. We also utilize some of our health team members to educate and monitor these patients in between their PCP visits. So we have a couple of options for patients to get some assistance in between those visits. One of them is for them to come in for a blood pressure check with our medical assistant. We've gone so far during COVID as to do that with a setup out on the sidewalk entrance of our office. We've also done those at the vehicle during COVID. So we've had to become more creative with that. But many of our patients, if they don't have the opportunity to purchase and own their own machine at home, they do feel more comfortable coming to the office in between visits to do that. We also have an RN care manager that conducts virtual and in-person visits with high risk and complex patients. And this can be as frequently as every 2 to 4 weeks, where she is helping them to go through their blood pressure logs, giving them advice about some adjustments that they can make, and then reporting those to the provider. Also, the further contact allows us more and more opportunity for education and reinforcement of their healthy behaviors. And it also helps the providers to avoid treatment inertia that was mentioned earlier, so that rather than waiting for that 3-month visit to come around and realize that the numbers have not been controlled this entire time, we have the opportunity to get some updated numbers through some of these opportunities and make adjustments in between visits rather than waiting months. We also encourage the patients to share their blood pressure logs on their own, and that's anywhere from dropping them off, emailing them. We do have a portal, although our patient population does struggle with technology resources. So that's not utilized as much as we would like to see, but we really just encourage them any way possible that you can let us know what those are. We'll accept it. We've even had them go so far as just calling up and talking briefly with a medical assistant to provide a list of some of their readings in the last week. All right, next slide. All right, and then the biggest thing is certainly for us, because our population is the majority uninsured or underinsured, is really just constantly keeping our mind open to what the barriers to success may be. For us, certainly, we always have our mind on the issue of health equity concerns that may be interfering with success for our patients. So I've just listed a few here and how we've tried to overcome those. Of course, transportation to get here for visits, or to provide us with logs, or to come for a measurement has been an issue. So we have increased the avenues through which they can provide us those. And we've even gone so far for provider visits to help them with DART passes and Lyft rides to get to those visits when needed. Of course, the financial limitation of purchasing a home monitor may be an issue. So as mentioned, we look for low cost or free options. I even have patients who go so far as to get their blood pressure checked at a local fire department that might be within walking distance of their home. We really encourage them to just find those opportunities wherever they can. And we share that with our patients. The other big one for us too is the issue of low health literacy and perhaps a lower educational level, where they really just may not understand a lot about why blood pressure control is important. And you really need your patients to buy into that first and foremost before you're gonna get them to get on board with measuring their numbers at home. So considering that you give them appropriate materials that are sufficient for their reading and comprehension skills, and also even combating myths that may be in their maybe culturally or socially bound, things like I'm probably fine because I don't have any symptoms, so my blood pressure must be okay. So continuing to combat those issues. And might be my last one. Culture and language again. We use a language line here. We're seeing more and more diversity of languages, particularly Middle Eastern patients, patients from the African continent with a lot of different diverse languages there. So making sure that those patients understand what we're trying to educate them on, and really also inviting the family members to take on a role in the care as well, sort of making them a part of the team. We found that that's been really helpful to involve family members in visits so that they also get the benefit of the education and can support the patient. And something we're working on to look at those social determinants of health even more so is bringing on a social worker who's going to be helping us to do assessments with patients and understand even better what those barriers may be. I think that might be my last one.
Thank you so much, Dr. Esquivel. Again, another remarkable program, and thank you for sharing the nitty-gritty details, the challenges, and the successes along the way. I'm going to ask all of our panelists to join us now. We only have slightly less than 10 minutes so I'm going to ask each of you a question. The one thing I do have to reflect on is through the course of all three of your presentations, I heard the themes of the MAP framework. I heard the importance of measuring accurately, both in the office and for the patient, acting rapidly, and the role of really thinking about bringing patients back and addressing timely care until we reach that control goal. And so many creative solutions around partnering with patients to equip them with devices and the confidence to use them, and being extraordinarily thoughtful in that regard, culturally sensitive language and with language appropriateness. The combination of science and creativity and data was just pretty overwhelming across all of you. So thank you. I could have heard each of you for about an hour. I'll start, I think, asking Diana just a touch more. Can you comment a little bit more on the sort of information flow? Many organizations have thought carefully about how the workflow happens and how patients are identified and devices are handed out. A little bit more about the information flow and how you kind of review that information. I know you answered a question in the chat or in the Q&A earlier, but if you could expand upon that and just any other final thoughts, and then we'll move to the others as well. Thank you.
Sure, absolutely. Great question. So one of the things I think that ties into this is patient engagement, right? How do we really get them to own and have that autonomy within their care plan? And so the biggest thing that I would say with our experience is that face-to-face education. The tools that we received from AHA was fabulous, right? The bilingual, just like every other speaker mentioned as well. Having that availability that it's already done, we don't have to reinvent the wheel, but now it's that connection that you have with the patient. So the face-to-face, there's also, there's actually a study through the Journal of American Heart Association that related specifically to the Hispanic and Latino population that we have the most of here. Their perception of it, their subjective access to the limitations that they have, and acknowledging that and working around that as well. One, it gives the opportunity to identify exactly what's going on at their home with their challenges, with the restrictions that they may have, addressing that, and then working around it with the multiple opportunities, the partnerships that we have. How can we help? How can we get them engaged? But them coming up with their individualized goals so that they can buy into their care plan and then have more autonomy on how they can assess their blood pressure and be better, and have that adherence to the medication or anything else that may be in the care plan as well.
So much. That collaborative communication is just so essential. Dr. Best, I want to turn to you. You touched on so many different things. I'm so glad you highlighted the digital divide and the creative approach you've taken with options. So that seems to be critical here. I wanted to find the comment you made around clinical inertia. And that is such, tell me a little bit more about how you got provider buy-in and what other sort of operational supports made that possible to address it. That's just such a critical part of hypertension control.
Yes, I really have to credit our pharmacists with that, because I think as providers, we, along with our patients, accept excuses. You know, I smoked before I came in. I had a sausage before I came in. But for the pharmacists, it's kind of cut and dry. There's no excuses. Let me see your blood pressure log. Let me see your blood pressure today. Okay, we're going to make a change today. So I really have to give her a lot of credit for that. But that also kind of reinforces it for me. So the next time I see the patient, I'm less likely to accept those excuses and really, you know, engage with the patient on what the consequences are. Regardless of the cause, the consequences of uncontrolled high blood pressure are dire. So let's make a plan and do something different today. So that's what I think helps me avoid the clinical inertia, even though, you know, I might be guilty of it at times. It's that collaboration that helps me remember there's more to it at stake than this one blood pressure. There's there's heart disease and kidney disease and all of that. So I think that's our solution to it.
That's really a great example of team-based care. So thank you for sharing that. I think the as we know, you know, reducing that risk as quickly as possible, to your point, is so important, and we can be patient for achieving long-time lifestyle changes that may impact blood pressure. We can always back off medications, but we're obviously trying to prevent heart attack and stroke to begin with. So thank you, and organ damage and all the other side effects of uncontrolled high blood pressure. So thanks for sharing that. And I'll point one last question to Dr. Escobar before we wrap up. I wish we had another hour. Seriously, this is such fantastic feedback from each of you. Dr. Escobar, thank you for emphasizing the investment that you made in staff education and training to set up patient education and training for success. Can you talk a little bit more about the buy-in process that both at sort of the provider and the staff level to really engage in accurate and sustain accurate blood pressure measurement in the process that you've undertaken so far?
Mm-hmm. I think a lot of that came from, you know, as a team, all wanting to perform better. I think all of us in the healthcare industry, we've all, you know, gone through an educational pathway where we really like the gold star. And honestly, I think that's what motivates a lot of the staff. So I think that's what started it for us, particularly. As I said, when in 2016, our performance on the blood pressure measure was only at about 41% control. And we've gotten up to 71, 72. So really seeing that for them, having them be a part of that, you know, engaging those members also in quality improvement meetings and committees, having them being a part of it, rather than just telling them this is what you are expected to do. It's been decided for you, here it is. We've really gone through those guidelines together. We update the evidence as it gets updated in the field, and we continue to educate our staff that way as well. And they feel great to see that their patients are doing better, honestly. So that has been sort of made it an easier buy-in. And you know, where these days even providers are you know, are graded, if you will, on how they're doing in a lot of different ways. So they like to see their performance numbers go up for their patients as well. I think for us, overcoming some of that treatment inertia has been an issue over time as well. But the monitoring in between visits is really, you know, if you will, you know, right in your face. Your patient's numbers are not great. Do you really want to wait around for the next couple months to do something about it? So I think the patients see that too. They realize, well, wait, I'm not doing well. It's been weeks and these numbers don't look good. So it really helps us to work together to just make improvements more quickly, because yes, the consequences are what is the most important thing.
I appreciate the idea of, making your team part of the design and solution. And I also recall you mentioning that, you all have committed to annual training and, making that an important part of how you sustain your skills. I mean, the recommendation is every 6 to 12 months, and it's you guys are walking that talk, which is wonderful. I want to point to our CEO for the last word here, Ms. Simmons, and ask you what, as a leader of your organization, the importance of leadership and a leadership commitment to prioritizing hypertension control. I don't know if you can comment on that just briefly before we turn to our last presenters.
I believe leadership is everything. At Tamagua, I am always thinking about what my clinical teams need. And so when we collect SDOH data, when we have our quality meetings, I'm constantly listening for the barriers. I began having conversations with the American Heart Association way before COVID to talk about the challenges we were having. We were meeting the hypertension goal. We love getting our award, Target BP, but I like talking about the challenges, and Veronica's team has been great. And then being proactive, one of the things we implemented during COVID was a food pharmacy, because we realized our patients could not get to us. We had a team of volunteers driving medications to our patients because they had to stay home. But when they did go to the food banks, those foods did not help. And so then we went further to work with our partners so that we came up with a formulary and grocery list and got volunteers involved in the cookbooks, and our patients could get a prescription if they were struggling and come through every week through a drive-through, turn in their prescription and get a week's worth of groceries. And so those are some of the things that I think at an executive level, not only do we need to hear the challenges, but then let's put some things in place while the clinical teams are down there, because I believe that if we didn't wrap around them administratively and bring on the other support, they would just be down there yelling at the patients, saying you have to get this under control.
Remarkable.
So again, leadership, if I could say anything, listen, and on the other end, we can create solutions to those barriers for our patients and our practitioners.
Thank you. Thank you all. I appreciate you generously sharing your stories, your successes and challenges through a more than challenging time. Again, leading with science and just then blanketed with creativity. It's just so impressive to see, and the gains that you all have made are just remarkable beyond the tireless effort. So thank you all for joining us. I have a feeling you'll be asked back again soon, because we do just whet our appetite. So I need to move on to our last two presenters today. For some conclusion, one of our other sponsoring institutions, I want to introduce Dr. Enron Rove, the Chief Medical Officer at Cigna Medicaid, where he leads quality of care, utilization management, and value-based initiatives. As a practicing internist, he specializes in chronic conditions in adults, including those with hypertension, diabetes, and cardiovascular disease. He's passionate about leading QI efforts on hypertension, and we're grateful to have him as the new chair of the Texas Cardiovascular Disease and Stroke Partnership. So Dr. Rove, I will turn it over to you for a few minutes. Thank you.
All right, thank you, and good afternoon, everyone. Oh boy, we had such a wonderful presentation and very rich discussions at the end by all the presenters. Personally, it's been a privilege to be part of the discussion, and I'm not going to take too much of the time. I'm probably, presenting here before your lunchtime, or almost cutting into the lunchtime, but as many of you know, and I've had the pleasure of working with some of you already. So again, thank you for all the work that you guys are doing out there. I'm an internist by training. I've been involved with cardiovascular disease work for the last several years when I started my journey with Baylor Scott and White Health. Now I'm the new chair for the Texas Cardiovascular Disease and Stroke Partnership. Many of you are familiar with the program. Our goal is to advance the cardiovascular disease control and stroke control for the state in the state of Texas by partnering with diverse group of individuals and entities and health systems. We work with Texas Heart Disease and Stroke Program, Texas Council on CVD and Stroke, and we aim to align our work and implement the goals and objectives of the public health strategies for addressing heart disease and stroke. for the years 2019 through 2023. So this is an exciting time. We're learning a lot more about blood pressure control, home blood pressure monitoring, and we look forward to having more people joining the partnership. Next slide, please. We started in 2007, and over the years, we have done some good work. Our most notable accomplishment to date, I suppose, is the genesis of the Hypertension Control Summit that started in 2018. The first conference started in 2017, and then we partnered with AHA. We continue to grow our work with AHA and the hypertension control. More recently, we have done Texas Check Your Blood Pressure Week initiative, where our main purpose was to raise awareness for hypertension check and hypertension management by providing a number of resources. We have had a number of social media posts and some BP screening events at different places. So we're very proud of that work. And as I have told, we are also working with the public health strategies for addressing heart disease and stroke for the years 2019 and 23. Next slide, please. And our current focus will continue the theme of self-measured blood pressure check and home blood pressure monitoring, because we now know that much of the control can be leveraged by partnering with patients, and patient-level data, home-level BP monitoring can be used not only for the diagnosis, but for proper managing by partnering with patients. So we'll continue to partner with the AHA to advance that program. Additionally, I am, and the partnership now is trying to prioritize cardiovascular disease and stroke work during the pregnancy continuum, particularly during antepartum and postpartum period. As you know, CVD still remains a predominant cause for morbidity and mortality during interpartum labor and delivery and postpartum period. And there are a lot of disparities for certain populations, including African American and Latinx populations, with regard to cardiovascular disease outcomes during the pregnancy continuum. So we'll continue some of this work as we continue with our partnership and partner with our stakeholders. So this is a good forum, and I hope that many of you will join our partnership, and there's some information. You can always reach out to me via email or to Melissa if you have additional questions and if you'd like to join us. With that, I'm going to turn it over to Alison. Thank you.
Thank you so much, Dr. Rowe, for your leadership in this space and for highlighting the many important roles SMBP can play in confirming a diagnosis, in titrating medications, and as a long-term engagement strategy. We heard a lot about that today. Finally, we're going to close this first of many sessions of the 2021 Texas Hypertension Control Summit with Nancy Eichner of the Texas Department of State Health, who'll be giving us some closing remarks and our call to action. Nancy is the team lead and coordinator for heart disease and stroke program at the State Department of Health, and she works to develop, implement, and manage projects and initiatives that address heart disease, stroke prevention, and treatment. Activities include quality of care programs, program coordination, partnership development, and stakeholder engagement. And I joined Nancy in the planning committee. It's always a delight to work with her. Nancy, please take us home. Thank you.
Thank you, Allison, and thank you to everyone. So I am a program of the Department of State Health Services together with the American Heart Association launched the Texas Hypertension Control Running Collaborative in July 2021. The purpose of the collaborative is to help primary healthcare clinics in Texas improve hypertension control rates through the adoption and implementation of SMBP policies and protocols. Clinics in the collaborative attend webinars on evidence-based strategies and interventions on SMBP. Support and technical assistance are provided to help clinics develop these SMBP policies and to tailor them to their patient population. The application process for the Learning Collaborative will be opening up again soon. Each clinic selected is awarded up to $3,500. For more information, including the complete application process, please visit our website listed on the slide and in the chat box. Yeah. Okay. Last, the Social Journal call to action. Last year in October, the Social Journal issued a call to action to control hypertension. The call to action aims to prevent the negative health effects of hypertension by identifying evidence-based interventions that can be implemented, adapted, and expanded in diverse settings across the United States. There are 3 goals and 10 strategies for this document. Goal 3 is optimizing patient care for hypertension control. And another goal is the strategy for SBP. Specifically, the strategy is to empower and equip patients to use SMBP monitoring and medication adherence strategies. The feedback loop on the right side illustrates the many components to support effective use of SMBP. We heard about many of these components today through the different presentations. Next slide. This slide has several action items. We would like to remind everyone to provide feedback on today's session. The link is listed on this slide and is included in the chat box. And for those wanting to learn more about SMBP, there is a SMBP Quick Start Guide along with other resources on the Target BP website. And thirdly, IO program, the Heart Disease Insurance Program, has a lot of resources as well for your hypertension control activities. And lastly, if you would like to join one of the 9 regional collaboratives in Texas or connect with your local AHA staff, please reach out to Kathy Hunt with the American Heart Association. With more people working together through this initiative, we can support more Texans on their journey to manage and control hypertension. And then this, as a reminder, here is a list of the 3 remaining webinars. The next one is on Tuesday, September 21st from noon to 1:30 Central Standard Time. And the topic is hypertension control and social determinants of health. If you haven't done so, I encourage everyone to register for these webinars. And please note the recordings and the slides will be posted after each session. Next slide. And we want to thank all of the sponsoring organizations for coming together again, this year to host the 2021 Texas Hypertension Summit. Hypertension Control Summit. These include the American Heart Association, the American Medical Association, the Texas Cardiovascular Disease Insurance Partnership, and the Heart Disease Insurance Program at the Texas Department of State Health Services. And that's like, and we also want to thank again all the speakers and to each of you for attending and your commitment to support Texans in controlling hypertension. Thank you again and have a wonderful afternoon.